Shirley Bighead, and Arnett Weber-Beats. And is there Judy here? Judy Sugar, there you are. Okay, good. And I'm glad we have one Sugar up here. But sour and sweet.
Holy, come here, me.
That's bad, isn't it?
Just wait till I get
What I said before, what we're going to do is we had scheduled a couple hours for this, but in talking with some of the directors and thinking about it as well, is that they're going to take an hour in total, so maybe 10 minutes apiece or so, to talk about their experiences with non-insured and maybe maybe their greatest concern. And as well, these health directors are the people that are actually in the front lines and managing your health system. So they've always been, I think, our strongest technical team, certainly in the communities. And the other thing as well is that after the panel goes for 1 hour, and then we will break out into groups, and we will be, in each of the groups, you'll have a short 2 questions. Basically, that'll feed into the last report. So we have 3 to 5 major gaps, and then 3 to 5 recommendations. And we will pick these up, and I'll try to pull them onto a chart so we get to see what the major ones are of everybody. So we can do that. So that'll be kind of like the task for the last hour. And after that, we'll take a break and do the community panel. And here we'll have, as I said, there's youth and elders, and Rhonda Myron from Standing Buffalo, who are talking about the long-term care, as well as Adrienne Cataract from the Buffalo River Dene Nation. She's a youth. And we have 3 elders, Senator Matilda Lewis, Noel Starblanket, and Gladys Wopaz Gray Eyes. So these are the panel that'll kind of finish it off and hopefully give us a good closure to the day. So without further ado, I will start over there with Arnett. From the Peter Ballantyne Cree Nation, by the way.
All right. Somehow I feel I was conned here, you guys. Good afternoon, everybody. I'm just going to talk about a few things that affect some of the communities, and I'm sure they affect most of you too. A lot of them have been brought up over the last day and a half in terms of some of the major issues, and I guess the ones that I hear the most complaints about are the medical transportation and the prescription drug thing. But everybody knows a lot of, has heard a lot about those, but just to add to some of the stuff in terms of medical transportation, I know for us that the taxi rates have been a major issue, and so when that happens, taxis aren't able to go or refusing to go because they don't have enough money to actually get there with the clients. And when they get there, even if they do, so I guess to back up, when that happens, then we're left in the clinic scrambling, trying to find people to take emergencies in oftentimes that need to be in right away to a hospital. And so that really does threaten patient care. They're also not given any time to wait. So if they take a patient to the hospital, and you know what, everyone knows what it's like being in an emergency room, and it can take hours and hours and hours and hours. And so they are expected to wait there for nothing. And if they do return home, they only get paid for one way. So you don't get paid to get them back, or you only get the one direction, not both directions. So those are just some of the things. But also in terms of medical transportation, you know, up north, and I'm sure it happens probably down in the south too, but when people have to come in for things like dialysis 3 times a week, sometimes they're traveling anywhere from 4.5 to 7 hours, depending if they have to come to Saskatoon in one day 3 times a week. And that's just, like I say, one way. Some of the people can't do it any longer, and they do move to the urban centers in order to not have to do all that traveling. But what happens then, they get to the city and they have no supports here. They don't even get a taxi to go to the hospital for the dialysis, and you know, they don't have vehicles and things like that. So that to me doesn't even make any sense. I mean, you're paying a taxi 3 times a week to come, but yet when somebody moves here for medical reason, there's no support to provide for them. I could go on and on about a lot of those things like meal rates, even in some of our communities when they have to go, say, in the van-based or by taxi, and there's, 6, 7, 8 of them going to one community, they don't get paid for a meal. Just because, if they were driving themselves, you might be able to get there and back within 4 hours. But when you're going with a group of people, you might leave at 9 o'clock in the morning and not be home till 5:30. So that doesn't make any sense to me either. It's not their choice. You have to go all as a group, right, the way the medical transportation works. Hospital transfers is a major issue for us. And we have done a lot of education to the people in the communities, and I know this all gets caught up about whether it's a province's responsibility or the hospital's responsibility or FNIHB's responsibility, but the bottom line is it's a patient who suffers for that. And when they say that they need the bed, then the hospital's supposed to pay. So we always try to educate the council and all the people that when they come to you in the hospital and say, do you want to go home, you tell them there's no funding for this, so that they have to take the responsibility. And that's been working pretty good, except it's like, again, like I say, almost a trick, because now they will pay for the flight from Saskatoon back to Flin Flon, but what happens is the individual gets the bill for the ambulance to pick them up at the hospital and take them to the airstrip, and then they get another bill when they get to Flin Flon because the ambulance has to come and pick them up at the airstrip and take them to the hospital. So those things are still out there, and they are creating major problems for both the client, who ends up getting bills from the collectors and all this kind of stuff, and certainly the band and for health services itself. Ambulance was talked about this morning, and there are, First Nations that do have ambulance services because there's no coverage in their area, and yet they don't get the same subsidy as the province. People who like this morning, are under the regional health authorities and get major subsidies. The ones in the First Nations, if they get one, are very small. And I'm talking about there's no other service in that area. So I know that there was some movement through FNIHB just on the pickup rates recently, but the kilometer rate is very low, especially when you're on some of those roads. Just a thing on escorts. There's a number of issues that happen that aren't taken, and I like the idea of that thing where you get approval for a year that they were talking about with that tool in terms of medication, but I'd like to see that also happen with escorts, because every time you got to give these reasons, sorry, they were talking about escorts. What I meant to say is for private mileage, because there are situations where it isn't appropriate for an individual and somebody who is very ill, especially if they might have mental health issues, or sometimes issues like Alzheimer's or dementia, where they can become very anxious and very irritable, and it's not their fault. But you always have to go into these big, long explanations. But if there could be approval for a year, I mean, that condition's not going to change. I mean, it's only going to get worse. So to have to go through that all the time, or if there's things like incontinence and stuff like that, where you have to explain all the time and convince people that they need to have this and not go in a van full of other people. Closest facilities for us, we have an issue because our closest facility is in another province, and anybody who may have noticed on the news, it's also a hospital that's been investigated a number of times, going through again. Even though there's been concerns about the care there, we're still have to go to that hospital. And what I'd like to see is that there could be a change where at least if we've sent the person to that hospital and they send them back right away, which they do 99% of the time, and then either the family or we have to just send them out to Prince Albert, that there could be, once the nurse has sent them there, that the nurse could make the decision, if she's not feeling comfortable that this patient is safe, that they can send them back to Prince Albert or Saskatoon, wherever it is they need to go on the second. They've tried it, it doesn't work, because we've had numerous individuals who have ended up in Saskatoon and had been discharged right away from the other hospital. I won't say which. Oh, I think I already did. Oops. Strike that from the record if I did. You can just look it up in the newspapers. It's out there. Drugs and medical supplies, that's all been talked about, but I do want to say that that also has an impact on those of us with transfer agreements and primary care centers, because those dressings a lot of times and some of the drugs, even like the Tylenols and all that, that ends up coming out of your stock, which we don't get those increases out of the transfer agreement. You're just expected to do that. So you are supplementing in a lot of ways what should really be under non-insured. The dental program, people talked about that, and that's issues for us too. But the last thing I just want to mention, and this isn't necessarily directly about non-insured health benefits, but I want to talk about the continuum of care. And we talk about a holistic approach, whether it's in First Nations now, and even mainstream talks about that now. But it almost seems that when you get to a certain age in health, in First Nations health, the funding stops. There's no support for long-term care. There's no support for some of those. I mean, yes, we do have home and community care, which isn't strictly an elders program. But when those services are so needed, we're talking about, again, between children and elders being the most vulnerable population. And what kind of strikes me about that is that when we talk about long-term care, you were expected to go into the provincial system. And it seems to me that there's a lot of similarities between residential school, in a way, that you were taking children out and putting them in an environment that, you know, we all know about that. But you're doing that with elders, and the worst part about this is it's most of those same ones who were in the residential school. There's no support for on-reserve long-term care. There's no support for subsidies for those First Nations who have taken the initiative to build their own centers. So the expense comes to the bands most often. And I'm just wondering, somebody talked about thinking outside the box or removing the box, but I'm just wondering if there'd be a possibility, even under non-insured, that that same level of subsidy could be paid to First Nations. And I'm not saying that they shouldn't have any kind of licensing and that sort of thing, because I do, obviously we want the best care and we have to make sure that the patients are safe and everything. But there couldn't be a way to have that subsidy billed through there, because in the province you get a subsidy if you're in a provincial one. So that's just something to think about, and I was just trying to think of ways that I do believe this is a big issue for all the First Nations in terms of long-term care and the additional supports that are needed out there in the communities to keep the people, the elders in the community as long as possible. So that has to be my 10 minutes. Thank you.
Thank you, Arnett. That's really good. Yeah. Yeah, just 5 minutes now. Then you can take 10 minutes. Just kidding. I'm bugging you. So, Helen, you're sitting next in line. Do you want to? Sure.
Thank you very much. I am Helen Burgess, the General Manager of First Nations Insurance Services Limited Partnership, located in Prince Albert, Saskatchewan. I would first like to thank the organization, the FSIN, and specifically Vice Chief Kim Jonathan for inviting me here and giving me an opportunity to come and tell you about the way our insurance brokerage works. I would like to thank the elders for their presence here. I always enjoy listening to all of the knowledge that they have to share. I'd like to thank our prayer lady for sharing her prayers with us. The senators, of course, for their words of wisdom. Just, I could listen all day. And I must comment that the meals that we have been given have been exceptional. So thank you for that. I'd like to give you a little bit of, so I am Helen Burgess. I'm the General Manager of First Nations Insurance Services. I am a licensed life insurance agent, and I'm a member of the Montreal Lake Cree Nation. And I have a couple of my staff here with me today, and I'll just introduce them. Cindy Johnson has accompanied me. She's also a long-term employee, and she is an expert in the field of group benefits as well. And I thought I had seen Beatrice Arcand here. Oh, she is here. She's a claims administrator as well. Both experts in the line of working with non-insured health benefits and our private insurance plan. So a bit of history about our brokerage. We are owned 100% Indian-owned by the Lac La Ronge Indian Band, with a small percentage of ownership being held by the Peter Ballantyne Cree Nation. We are located in Prince Albert, Saskatchewan, although we do have a sub-office here in Saskatoon that we man a couple of days a week. We have been in business for just about 27 years. It has not been an easy journey in the very early days because, you know, when we first kicked off, the insurance industry was one that was primarily dominated by, and with all due respect, the older white man generation. So it was a struggle, but we were able to form very solid relationships and of mutual respect with the insurance industry providers, and so we've been able to thrive. We are licensed in all of the Western Canadian provinces as well as the 2 territories and Nunavut. 98% of our client base is our First Nations bands and their institutions. We have a dual passion at our office that certainly does shine through daily, and I think that probably explains some of the longevity of our employees there. Our first passion, of course, is to bring that extra protection and coverage to the people of our First Nations in areas that are otherwise lacking, and non-insured health benefits being one of them. Our second passion, of course, is to do our part to protect and enhance treaty rights. Our office has a staff of 10 individuals. 9 of us are status Indian women. So we have experienced all of those shortfalls in terms of the non-insured health benefits that each of you in this room have. So we're coming at it from a very personal perspective as well. Chief Isaac Venn, in the mid-1980s, had a vision, and that was he was recognizing the sometimes not so gradual deterioration of non-insured health benefits, and so it was his vision to put a brokerage in place that spoke specifically to preserving and enhancing treaty rights, treaty health rights, not ever replacing or duplicating them. And as a result of that, First Nations Insurance Services was incorporated as a company on June the 10th, 1987. As a brokerage, we do provide full benefit packages to our groups. Our plan of choice is our plan that we call our FNIS plan. That plan protects and enhances treaty rights. We're able to do that by special agreement with Health Canada in Ottawa, an agreement that we've had the ability to protect and preserve since plan inception, and an agreement in which our plan participants are able to exercise their treaty health rights first and foremost, and use our FNIS plan, the private plan, only as a backup when the prescribed medication or treatment is not covered by non-insured health benefits. It's our belief that if we don't do our part to protect treaty health rights, they will dissolve at a faster rate than they already have. And we're all witness to that. Within our plan design, our status participants' rates are significantly lower than any non-status participants, and that is because we feel that our non-status participants do not have treaty health rights to fall back on. And so we have structured our rates in that fashion. As I said before, our plan does not duplicate, replace, top up any benefits provided for by the non-insured health benefits. And in fact, it excludes all non-insured health benefits. So there is no interference run between the two. It's not considered a third-party plan, nor is it considered a wraparound plan. From our point of view, if it is a non-insured health benefit, our plan excludes it. If it's not covered by non-insured, our plan covers it. It's very, very simple. We have been able over the years to preserve the integrity of our plan. It hasn't always been easy. I've had a number of challenges, certainly, we at the office. When Health Canada comes up with a new, I always call them curveballs, and one of them, I think, one of the biggest ones that we've witnessed is when the contract to adjudicate the claims for non-insured health benefits across Canada is awarded to organizations who don't have a system in place to deal with hundreds of thousands of claims that roll in from across the country from our First Nations people. In 1997, that scenario had a horrific lasting effect on providers across the country. And in the case of the dentists in Alberta, and we do have clients there, so we're aware of it, it affected their approach to dealing with First Nations clients to this very day. In that worst case scenario, in that period of time, some dental offices were waiting for a full year before they were paid from that particular adjudication company for services rendered to First Nations clients. And that has formed their lasting attitude towards, that they take towards delivering services to First Nations patients in that province. I just got the sign. I guess none of us are exempt from that. Just to wrap it up then, because I've been directed to do so, we are the plan that does not fit Ottawa's directive that if you have a private plan in place, you must use it first. In fact, we are the only plan that differs from that. If it is a non-insured health benefit that should be taken care of by the federal government under the treaty health rights, we fully expect and actually demand that our participants must use their treaty health rights first. We do everything. We administer that from our office. We are able to help our clients on a one-on-one basis, and we're very actively involved. I see many of our clients here in the room. I was so happy to see Denise here yesterday because she has been my go-to lady. We've been friends for many, many years now. We do sort of operate, I guess, on the old adage that if you're not part of the solution, then you're part of the problem. And that's why we continue to do our part to preserve and enhance treaty rights, but not ever to replace or duplicate them. One of the gentlemen this morning asked the question, and he has a very valid concern. Why should he have to have additional insurance when, in fact, he should be fully covered by his treaty health rights? And yes, he's correct in that, except that we know that that's not the situation anymore. If we want to have those additional health needs met that are not being met by non-insured health benefits, then we must, at this point in time, take those steps for ourselves to make sure that we have that protection. Thank you so much for your attention.
Thank you, Helen. And I'm sure you have a card or a pamphlet or something. Okay, good. Oh, I don't have to introduce this guy's gone already. Okay. Albert Jimmy from Onion Lake.
higanaya. Nanas kumonaya, nanas kumogan ga kiteyak, ga kisemutsik, taksi gomina kiksep. Aya, Good afternoon, everybody. I just like to thank the elders that did the prayers both days, yesterday and this morning. I'm not going to dwell on the issues I experienced because I think that has been done extensively already. We all claim non-insured benefits is broken. Why? We need to talk about how we're going to fix things. I had a list of the issues here, and it pretty well, the same what was talked about, like prescription medications and hospital-to-hospital transfers and the dental benefits in the appeal process. They don't all work for us. It's not benefit to the clients. First of all, I'd like to talk about the what Onion Lake has for services. And we have a pharmacy. I guess in a way we're not administrators, but providers also for the services. So we provide pharmacy services, ambulance services, and recently MRI services, and of course lab and X-ray, and also physician services. We were fortunate to have the doctor that spoke yesterday 40 years with us. And the last 30 years, last 20 years, he practiced full-time in our reserve. And most recently, we managed to negotiate with our health regional authority. I guess I could say negotiate, but there hasn't been any formal agreement to this day yet. They're providing 2 additional doctors for us. So we have part-time, or actually 3. The one doctor, his wife is a doctor too, so it's a doctor and wife, providers. But anyway, and also Dr. Warburton is still practicing part-time. So actually we have 4 doctors. And besides that, we have 2 full-time nurse practitioners. And recently also NIHB are providing a 3rd nurse practitioner that comes 1 day a week. So really we have 7 medical practitioners in our clinic besides lab and X-ray. What does that to lab and X-ray? They were overworking the lab technician. There's only 1. We've gone through 2 lab technicians that have resigned or don't want to work in our clinic. Too much work. So we finally got some funds from NIHB to hire the 2nd lab technician. We're in the process of hiring that lab technicians now. But anyway, I just want to, talk about the solution. We all heard numerous times Saul Sanderson speak to us. We have to try or implement or negotiate or develop a new fiscal arrangement based on our treaty, rights. And that's entrenched in the Constitution. We heard yesterday if NIHB doesn't have any legislative base to deliver the services, so we got a stronger, mechanism to go by. So that's what we need to do. And Onion Lake has evolved and developed our own health system. So overall, all nations need to develop, I guess, maybe, I don't know what it'll look like, a first nation's health system. Because not insured, we all come to conclusion it's broken. What about insured benefits. That's the provincial side. That's broke too. You know, there was a review done. They all agreed that we have to have another provincial health system. And I just want to share, you know, the trip we went to a few years back, which is Alaska model. 4 years ago, we took a trip, just look at their model. We found out like we were operating same way in Onion Lake. That's the primary care health initiative that the province now are trying to implement. They have pilot projects, I think 5 in Saskatchewan, primary health care. But they took that from Alaska First Nations health system. When we talked to them, they described what they had before. They had fee-for-service, which that's what we have. Long wait time. You all know the wait time when you go see to the hospital, long wait time, or a doctor. And there's no link, meaning the doctors work separately. They have their own business, clinic to make money. They work separately. They don't work with other health professionals like community health people. So, but we've been doing that for the last 20 years. And they didn't have any traditional medicine incorporated in their health system from the state in Alaska. And this was amazing to me. They say before they had their own health system, pain medicine was the highest cost. And today, we keep hearing FNIH, that's one of the highest costs in the expenditures. After they negotiated their agreement with the federal, you know, government and the state, it's the same, you know, I guess, our governance structure in Canada, you know, the federal and the province. That they had the same thing. So they negotiated, they want to develop their own First Nation health system. They completely reversed everything, what I explained, what they had before. Today, their health professionals are on salary. And by the way, those 3 doctors that were sent from our health regional, they're not fee-for-service doctors. They're paid salary or alternate payment. They refer to sessional payment, and they're paid by the day. Doesn't matter how many patients they see, they still make 1,000, and they like that. They're from South Africa, and they have the same system over there, I guess. But anyway, losing myself here. The wait time also decreased. Today, if you're Alaska First Nations and you want to see a doctor, you go to their clinic and you will see a doctor. No appointment. They'll see you that day. And I think I mentioned this, no fee for service. All their health professionals on salary. And their traditional medicine is incorporated in their system. And that's what really, I guess I was amazed. Their traditional healers work side by side with the health professionals. And if the doctor you see of the day finds out that there's an issue bothering you inside, they will not prescribe pain medicine. They will take you to the office on the side. They'll ask you which one you want to see, the traditional healer or contemporary mental health therapist. You have a choice. And these patients start their therapy right there. Today, that the high cost of pain medicine went right down. They don't have that. And the funds they save, the federal government inject that to the health system, and they keep enhancing their their system. Today, when we visited, they have a regional hospital, their own First Nations hospital. So I guess, in a way, that's what we need to do, our own First Nations health system. And Onion Lake has progressed so far. Right now, where I said we have these medical professionals come to it, there's really no concrete contract written with Saskatchewan Health or Regional Health Authorities. Vinny actually committed in providing additional nurse practitioner, but they're telling us we cannot show it as salary for a nurse practitioner. We have to put it under different category. See, they're not coming up front. So we need to have a concrete agreement with the federal government, bilateral, first, and then also with the province, because we need them. An example has been made with child welfare agencies. They're implementing the Provincial Act. In time, First Nations will have their own. Till then, they're borrowing that. And INAC providing 100% of the operation. That's the same approach we have to take in healthcare. Time? Thank you.
Oh, that's very good. So we have the sugar up here. So it's
Good afternoon. My name is Judy Sugar. I'm the health director for the Paipot First Nation. For those that don't know, we're the Paipot First Nation. We're located 30 miles north of Regina, and we have an on-reserve population of 550, roughly. Currently, our medical transportation program consists of private mileage only. We do not run a van model system. And we employ one medical coordinator and one clerk. And those are both part-time services. On average, they process 312 private requisitions, with the majority going to see the general practitioner in Regina. Non-insured medical equipment and prescriptions are processed within our ban when we receive requests for non-insured equipment and prescriptions, oftentimes our ban subsidizes those non-insured equipment and drugs, and that is reviewed annually with Chief and Council. I don't want to dwell too much on everything, the problems that we have heard in the last 2 days. We have experienced everything that the hospital-to-hospital transportation. We have experienced the portability problem from province to province, and our treaty cards not recognized in, say, Manitoba. And we've received bills from other provinces regarding our on-reserve members and off-reserve members. Oftentimes, our off-reserve members also seek our services, even though we're funded for only on-reserve. It is a broken program. Non-insured is definitely a broken program throughout our province and throughout Canada, and it needs to be fixed. And I'm looking forward to the next sessions and listening to some of the other communities and talking about solutions to these problems. And one of the things I also wanted to emphasize is the medical transportation, our administration staff, that those positions are totally underfunded, and they never change because they're in a set agreement. Our clerks are overworked and underpaid, and that needs to be fixed immediately. I would like the FSAN to advocate for those positions to be reviewed, definitely, and to be funded appropriately. These girls do a lot of work, and they're their forms and their requisitions that they need to do have to be accurate, and it's a lot of work. And I sure appreciate the staff I have, the two ladies that do all our work and all our requisitions. Like I said, there isn't a whole lot I can talk about that hasn't already been discussed today. But it's time we do come up with solutions and do come up with a plan to move forward and to bring non-insured to the same levels as the other community health programs. Thank you.
Thank you, Judy. Darlene. Darlene Arnault. No, not Darlene, sorry.
Good afternoon, everybody. I'm Darlene Arnault, and I've worked in the health field for many years, and I consider myself an advocate for First Nations. We spoke of a broken system. I think that's been mentioned by everybody here. But I guess the question I wanted to bring to the group is, what are we doing about fixing it? What's our responsibility? Because to me, the treaty right to health is what's at stake here. The non-insured health benefits program is a small portion of what's left of our treaty right to health. And we have to preserve that at all costs. But how do we move to that? And I guess when I'm looking at things like accessibility, now when the treaties were signed, accessibility was one of the things that was promised. We were supposed to be able to get our treaty rights no matter where we went. And our treaty right to health was one of the major ones. And yet now we're going to the nearest facility, and sometimes that creates a 6 months to a year waiting plan, but it's got to be to the nearest place. We can't go to, for instance, in our community, even though they're doing ultrasounds, CAT scans in other areas, and we could get them in faster, it's not covered because it's not the closest place. So those are the things we have to try fix. The other thing we have to ask ourselves is what we're asking for equality of service, or are we asking for equality plus? And what I mean by that is there other benefits we should be getting because we have a treaty right to health. What does that plus mean? To me, for instance, look at the drugs. Can I get some water, please? When you're looking at pharmaceuticals, and I'll use Plavix, for instance. Now, Plavix is a drug that's prescribed to you after you have a stent put in. So you have a heart attack, they put a stent in. They give you a prescription for Plavix to prevent clots. Well, Plavix is by prior approval. So sometimes it takes up to 2 weeks to get that drug when you're in the north. By then you could be dead. How many other drugs are there like that we have no control over? So some of those that are life-threatening should be on an immediate basis and no prior approval required. Now, if for drugs that aren't covered, what can we do about that? Now, I'm glad to hear, I think it was Denise that mentioned that some of those drugs are being prior approved for a year period. That will help some. Standardization. What do we mean by standardization? That means we should have the same treaty right to health in Nova Scotia, Saskatchewan, all the way across. And that's not happening. Because we see caps on stuff. For instance, oxygen. Now, I had a client from Big River that phoned me. She said she was capped to 200 cans of oxygen a year. So she could only get 200 tanks a year, but she was using 260 tanks. She had 30% lung capacity of one lung. And so I phoned for her to find out what the reason was. And the benefits person I talked to at non-insured answered, well, we don't want her to get addicted to oxygen. So, needless to say, it was an appeal and we won. But things like that should not have to go to appeal. There should be a simpler process. Now, when we're looking at the voice of the First Nation, where are we there? Like, we're the ones being affected. But when there's a change in policy, as a nurse, as a health director, where do I go? I go to the pharmacist that we deal with, because they're the ones that get the information first. We never get notified. We find out when somebody comes in and says, this isn't covered. Now, just before I came here, I got a call from the hospital. One of our clients was in Emerge, and they had put some a splint on her, and they had already put it on. And she phoned, she said, you know, the splint isn't covered, so they're not letting me leave till I pay for it, and I have no money. And I said, well, tell them to keep you as collateral. I mean, what are they going to do? I said, tell them to bill us and walk out, and I'll deal with it after. But the red tape we had to go through to get that woman discharged because she had this splint put on before they had approval. Now, that's a broken system for sure. Hospital-to-hospital transfer has been mentioned. But what wasn't mentioned is that if you're 65 years old or over and you're going to your place of origin, so you got transferred to Saskatoon, now you're going to be sent back to L'Orange because they need your bed. So they're going to charge you for that ambulance cost. But did you know that if you're over 65, they'll charge you for the full cost of the trip, which is probably about $15,000 to $2,000. I'm not sure of the amount. But if you're non-First Nation, you'll only pay $250 for that trip. Now, isn't that discrimination of our elders? That's a broken system again. And the same goes for prescriptions. If it's a drug covered by Sask Health, but not by Finney, there's a subsidy for non-First Nations. Our First Nations have to pay the full cost. Now, to me, these are human rights issues. And as band members, as leaders, what can we do to fix the system? What's our responsibility? Because when we have treaty rights, with those rights, we also have responsibilities. So I say that a lot of these things we're letting happen. And I guess if we let it happen, it's going to keep happening. So part of the strategy I'd like to see is what can we do as First Nations to stop this from happening? Because I think we can. And when you think of the last issue that was brought up at an assembly like this, that was a consent issue. Now, it got overpowered by some other negative things, but at the same time, we killed consent because there was unity in the First Nations to fight that issue because we valued our privacy, and we won, and we forget that. Methadone was mentioned. Now, as a nurse, I have my issues with methadone, but our reserve has a pilot project on methadone. Now, methadone works for some, but you have to have a program with it. And there's no program that goes with methadone in a lot of places. You're put on methadone, you have to hitchhike back and forth to get your medication. Whether it's freezing or not, you still have to go. There's not enough research into the effects of methadone. And before I left the Takakoop, what we were working on is a project to try to get a pilot on Suboxone. Now, Suboxone is a drug similar to methadone that will help you get off the opiates, but it's not, it's kind of, it wasn't covered at the time, but now I think they've changed it to a special status drug. There's less side effects. You don't have to line up at the drugstore to get your meds. It's a take-home drug that's safe. And it's been used in other areas and proven to be safe. Now, how much better would that be for our people? Because I can tell you now, we have a lot of addictions. And a lot of them use the service of non-insured health benefits. Direct billing to First Nations is what we're dealing with now. Because FINI isn't paying, or non-insured, the program is not paying those bills as fast as the providers want, for instance, for that root canal. What a lot of them are telling us is, yes, we'll do the root canal, but your patient has to pay it first and send the bill to FINI. Now, if you're a secretary, you have 6 kids to feed at home, and you get a dental bill of $800. How are you going to afford that? The other area I see this could really impact is our children have the most dental surgeries of anywhere in Canada. Like we have a lot of dental surgery with our preschoolers. And as First Nations, we got to do a lot of teaching in that area to reduce that number. But the ones that are needing surgery, now if they start direct billing for that, how are we going to afford it, and what impact is this going to have on our children? I think these are the things we have to consider. And I like Denise's idea of a minister's letter, because I know ministerial referrals are dealt with fast. And those are some of the strategies that we should be looking at. Chiropractors, it's less invasive, yet it's not covered. Podiatry, a very important field. When you're a diabetic, your feet are very important. Now, our chronic program is a non-funded program, and yet the purpose of that program is to prevent you to going into the complications later on of the chronic diseases. And yet there's no money in that program. Now with the ADI there, a lot of places were starting to do foot care for people, and there was mention of shoes. Well, there was one doctor that came to one of the communities I was working at, and she did a lot of work measuring feet, and she brought a whole bunch of shoes. I don't know if there were leftovers like the elder talked about, but I was kind of chuckling when she said that. But so every diabetic got to pick shoes, and she billed the cost to Finney. And I was really impressed with her because I thought, oh my God, like, you know, what kind of pull does she have? I've never heard of shoes being covered. Like, looked at the cost of them, they were anywhere from $100 to $250. So I thought, well, she really has a good deal with Finney. I like this doctor. Well, the other day I just heard from one of the nurses, they said, did you know that Dr. So-and-so is going to court? I said, no, what for? They said, well, Finney's suing her because she provided a lot of shoes to people and charged them to Finney. So I guess they're trying to recover their money. So, so maybe we should get her on hand with us. But, yeah. So payer of last resort, I think, was mentioned. And I really have had a lot of conversations with Helen. And I really thank her for the program she runs, because her program is the only one I know of that has a payer of last resort clause. And our understanding is that non-insured health benefits is supposed to be a payer of first resort. But they always claim to be payer of last resort, except for First Nations insurance. They're the only ones that have a clause in their agreement that, as far as I know. And how they did it, I don't know, but I really hats off to you, Helen. Yeah. And I think my 10 minutes is up, but I could say a lot more, so you better stop me, Benita. And and the other thing I'd like to say, I'm the first of the sours after the sweets. Seal is more sour, and Shirley is off the scale. She's the most.
Boy, they're really hard to control here. Seal Turner, Saskatoon Tribal Council.
Good afternoon, everyone. Okay, so I'm the first of the sours, but that means, or the second of the sours, which means Shirley's way more sour than me. So, the issues that you've heard, I don't think are new to anybody, and they're certainly not new to our communities of the Saskatoon Tribal Council or our band members. So, I think that one of the things that, as I was reflecting on, making the presentation here to you today is, the saying of a death by 10,000 cuts. And I think that that's really an appropriate way of describing what's happening to our treaty rights over these years. For those of you who were with us yesterday morning, Tribal Chief Thomas, our Tribal Chief from Saskatoon Tribal Council, spoke about his experiences going back into the mid-1990s and forward to the time where we had the moratorium on any changes to non-insured health benefits, and that was the last time that we actually, didn't see any, continuing cuts to our programs and our services. So I think it's important for us to remember that, and he had cautioned us to say, if we're partnering with someone, then we need to be truly partners. And we, as the technicians and the leaders and the support staff and everybody involved and recipients of our obligations to our treaty rights, needs to step forward and take responsibility for that as well, and to work together, obviously, which is our collective value. And that kind of ties into my second thought. If it's meant to be, it's up to me. And that's basically what Darlene was asking us to consider. What are we prepared to do every day, day in and day out, when it comes to non-insured health benefits and our treaty right to health? Because we talk about the two as being interlinked, but really non-insured health benefits is sort of just the only visible embodiment of the government's responding to our treaty right to health, right? I mean, non-insured health benefits isn't our treaty right to health, but it is that it's that way that we connect everything. There's a couple of things, that haven't yet been raised that I'd like to mention. Not only is the government cutting the benefits under non-insured health benefits or contracting them. But we've also got an activity right now where Indian Affairs is trying to offload some of their responsibilities into another government department or into another department. And for those of you who are involved with early childhood intervention programs, you'll know what I'm talking about. There's been an announcement recently made. And of course, the thing is that, oh, we'll gladly give it over because, I mean, really the authority from Treasury Board really rests with FNIB, but we're not sending over any money for it. Right? So it's an offloading even between departments on the issues of non-insured health benefits. And when we're looking at ESIP, that basically bumps up into another area that's really important to us, and that's Jordan's Principle, right? Jordan's Principle, where a child doesn't need to be taken into care in order to receive medical services that they're entitled to, or that they require to live and thrive. So, I mean, those issues are all tied in, with all of the other issues that we face. We can't separate it and make it just individual. So I guess, the question that I always ask is, where are we going? What are we going to come out of here today or after these 3 days with? What direction are we as technicians willing to provide our leaders who are meeting tomorrow to say we need to, either we need to do the letter writing campaign, we have to have, all these ideas have to be brought forward so that our leaders have a strong base and know that they're backed by their people. Because another area that really has me concerns is, as technicians, every day that we work in health, we make a decision that has an impact on our treaty right to health. And it doesn't matter if we're a nurse, a community health representative, a medical transportation clerk, we are making decisions that have the potential to impact. And for all of those health directors that are responsible for either signing off contribution agreements or making the recommendation to chief and council about signing off contribution agreements, or who aren't being consulted by leadership and basically say, oh, it's not my responsibility, the treaty right to health clauses have been removed from our health agreements for some time now. Now, STC has fought over the last few years, and we've always been successful in having those reintroduced. How many other organizations are insisting on the treaty rights clause being included in our agreements and or the inclusion as a very minimum of non-derogation clauses?